You know, I had a feeling that Dr. Rothwell would be extremely smooth and probably throw in a little bit of some foreign languages, so I'm going to try my best to rebut. I'm Cameron Dezfulian. I'm at Baylor College of Medicine. I'm not a cardiologist. I am active in DHA, and I threw up all my fellowships there just to say that I think the collaborative nature of my career path and also just of our society it's one that makes sense. And you know, this is a time when I think our country is seeing a lot of division in this idea that, like, let's go it alone. So some people would say that's more efficient, but I would warn you against that path of efficiency. And I'm going to make an argument that there are better ways to go. So first, I think for those of you who've read this book by Simon Sinek, you have to start with why, or another way to put it is, what is the raison d'être for an organization, right? Now, I like raison d'être because it's French, and French sounds fancy, and I knew my opponent would be quite fancy in bringing out some Latin. And, you know, since the rules of this session are laissez-faire, and he has that je ne sais quoi, I might as well be avant-garde and move forward. So I would say that the three points that I have here are really the raison d'être for our organization, right? Which is we want to optimize patient outcomes, which means we want to talk about staffing models and evidence and what we can do. We want to guide the evidence and the research that's going into the field, and we want to develop training pathways, and that's what we've been talking about all morning. My argument is all of this will happen much better and will be accepted much more widely and publicized much more widely through collaboration. So what are some of the reasons for collaboration? I'm going to lay out 4 points you know, somewhat quickly because I want to allow for the rebuttal. First of all, I'll argue that critical care cardiology is very multidisciplinary, and so you need this broad range of knowledge, which no one person is going to have, nor is one organization. So collaboration makes sense. I think that the ability of us to optimize our patient outcomes in the unit depends on collaboration. I think the collaboration with other organizations is also the most feasible pathway and really the most reasonable, and I'm going to show a problem that I don't think has been recognized so far within our organization, but hopefully I'll shed some light on it. And then finally, collaboration is morally right, and I'm going to make a case for that, which I know people don't like that, but we're going to go there. So first of all, what is the multidisciplinary nature of critical care cardiology? So everything I have up here has been talked about, and these are all different skills that you need to be an expert critical care cardiologist. More importantly, these are all areas where there are existing societies that actually have more expertise than any of us, because unfortunately, being an intensivist is a little bit of being a more of a jack of all trades than an expert in any one, and that's a necessity because of how broad what we do is. But if you lean on other individuals on an individual level or on other societies on a societal level, I think you benefit from them. And over these organizations, I think Dr. Roswell did a great job pointing out the organizations, the AHA and ACC, that bring it all together, right? And we lean on them routinely, and I think doing so is what's going to help us to publicize our cause. Now, he may tell you a different path, right? That we should go it alone, and I've even heard that he's planning on making HRS be a part of one of our subcommittees and annexing them. But I don't think that's the route to go. We shouldn't be giving tariffs to their members. We shouldn't be trying to annex their organizations. I think that we should be collaborative. Now, to optimize patient outcomes, you really need teamwork, right? So this was a shock for me because I went into medicine and critical care medicine because I wanted to save lives. And the shock for me was that as an intensivist, I don't save lives. I just support lives while someone else comes along and saves their life, right? So there's a lot of other things that actually save their life, and my job is keep them alive until one of these things happen, or one of these organizations comes up with an idea that we integrate with our own and push forward. So I think all of these different things that I'm listing are things that involve other concepts that are not necessarily within our wheelhouse. We touch on them, but we're not the experts. So I think to have an understanding of all of these therapies and these different specialties really is best accomplished through collaboration. I think I learn about all of these by going to places like AHA and ACC and attending sessions. Many people in this room, I know particularly the fellows, come to this meeting, you go to the NYU meeting, you go to the Minnesota Critical Care Cardiology Education Symposium. That's already 3 meetings. Are you also going to go to HRS? And are you also going to go to SCI? And are you going to go to all those other meetings? Or are you just going to go to HA or ACC and get everything in one place? And then next is how do we integrate all these within an ICU? And I think that requires collaboration on a systems level, and this is where bringing together the organizations to create those system-based documents is helpful. So the next thing is just, I think it's the more feasible path forward, right? Publication in journals with high impact factors get read by lots of people. Notice that the different citations that Dr. Roswell brought up were in journals that are from the ACC, and there are some in the AHA, and these are the high impact journals of our field. I think funding for projects is a big deal, right? Right now, the AHA is behind the NIH in funding dollars for cardiovascular medicine. It's the biggest or second biggest funder. And at the rate that the NIH budget is being cut, it's soon to be the first. So we should take them seriously. The development of guidelines is obviously a big part of what we do. And for us to develop guidelines, we need to collaborate with the experts in these different fields. And then finally, if we want to have educational seminars with broad attendance, we'll do well to be positioned within places like the annual AHA and ACC meetings and have presentations that folks can come in and maybe draw in new people into the field who are interested. ACGME is something that all these different organizations play into what are the requirements for different specialties. And I'm not going to argue that because I know Dr. Roswell knows it better than me, but having these organizations on our side through collaborative reaching out is going to make this a much smoother process. And then finally, this is the problem with fellowship that hasn't been raised at all in this meeting. And to bring up this problem, I want you guys to think about Meet the Parents. So this movie came out about 20 years ago, and in it, Robert De Niro, who's the father-in-law, meets Ben Stiller, whose name is Gaylord Fokker, okay? And he has to introduce himself. He says, how exactly do you say your name? And he says, well, just like it's spelled, Fokker, right? So there's this awkward moment, right? So if you're a fellow in the AHA, you're a FAHA. If you're a fellow in the ACC, you're a FACC. What if you're a fellow of the SOC? Everyone say it with me, slowly, awkwardly. FAHA. I think I'm going to just stick with FAHA and FACC for now. But some people are proud. Some people are proud to be a Fokker. And I do admire something about that spirit. So finally, the question of morality, right? So, everyone bases their moral on different things, and I'm Christian, so for me, the Bible is the Bible. So I went to the Bible to find some morality behind SOC, right? And I landed on this verse from 1 Corinthians, core being the Latin for heart, right? Maybe dumb luck, maybe the Holy Spirit, but let's read it together. There's one body, but it has many parts, but all its many parts make up one body. And suppose the ear says, I'm not an eye, so I don't belong to the body. By saying this, it cannot stop being a part of the body. If the whole body were an eye, how could it hear? If the whole body were an ear, how could it smell? The eye can't say to the hand, I don't need you. The head can't say to the feet, I don't need you. But God has put all these parts together and has given more honor to the parts that they didn't have. So, Paul wrote this to the Corinthian church, but I think if he had written to SOC right now at this pivotal moment, he might have said something like this. There's one heart and many parts, and all the parts make up the heart. Suppose a mitral valve says, I'm not an SA node, so I don't belong to the heart. By saying this, can it stop being a part of the heart? If the whole heart were a mitral valve, how could it keep a beat? If the whole heart were a valve, how could it pump? The SOC can't say to AHA, I don't need you. The HRS can't say to SCI, I don't need you. But God has put all these together with the representative organizations and has given honor to the new kid on the block if we're not too presumptuous. So I will leave with that. And so hopefully I've proven to you that SOC should collaborate because it acknowledges the multidisciplinary nature of critical care cardiology. Only through collaboration are we going to optimize outcomes, get the word out, and improve provider education. Collaboration is definitely the most rational and most feasible path forward. And then finally, collaboration and inclusion of the diverse organizations is morally right. And with that, I will tell you, don't be fooled by false prophets, even if they are smooth-talking and devilishly handsome.
We could leave that slide up. So I thought that was a great sort of debate of why we should have multiple societies coming and collaborating. And I agree that we should have multiple societies, but I guess the question is when. I think if you start off or if you go too soon with multiple societies, then you don't have the collaborative or the unified voice to move the field forward, to have identity and recognition. And so I think we all agree that collaboration is really important, but the question is, when should societies sort of newly form? How many should newly form? And I think that's an important question. So is now the right time where we should have a FACC? I would say yes, because I think we have, as a single society of ACC, critical care cardiology, as I've shown in the slide before, we've done a lot. And this has been a journey that all of us have been on together. And so I just want to reframe it. Yes, we should, and I think the time is now, but you have to start with a unified single society to start the message, to start the guidelines, the consensus statements, and all the other initiatives. So that will be my rebuttal to this beautiful picture. And I would always say critical care cardiology was always great. We don't need to make it great again. Thank you.
Well, here we actually have a point of agreement. So I first of all agree that critical care cardiology has always been great, and I also agree that having the society makes a lot of sense. The point, though, I would make is that I think the way our society is going to flourish early on is actually what's gotten us to this point, which is working through other organizations and co-branding, so to speak, publishing statements and scientific statements, guidelines with other organizations. And the nice thing about having a smaller society is we can be very nimble. We can approve and kind of co-endorse a statement in a way that if you've ever sat on an AHA guideline committee and had to deal with the bureaucracy, is not nimble or anything close to that. So we actually have the ability to play a part, and we represent critical care in a way that others don't. So I think that other groups will reach out to SOC to get kind of that endorsement, and it's the best way for us to get our name out as a new society and to be essentially recognized as the experts in critical care cardiology. So I think that's the collaboration that we're talking about. But in reality, we're probably not all that far off.
Thank you to our excellent debaters who I think presented very compelling arguments for both sides. Over the last few hours, we have heard from different debates and different panelists that there still remains a lack of kind of cohesive messaging out there at the national and at the administrative level to represent the diverse workforce that we have within critical care cardiology. I mean, just on this panel, there are so many different pathways to the summit of critical care cardiology that we have all taken to reach there. So my first question for the panelists is that how can we do a better job of first kind of reflecting upon ourselves as the workforce in this critical care cardiology space and the diversity that lies within our workforce, and then ultimately advocating for it. Because if the FTE looks different for a critical care cardiologist compared to that for a general cardiologist, it sure as hell looks different for somebody who's trained in ER and critical care and helping us with critical care cardiology patients, or pump critical care, or even within cardiology for somebody like myself who's cross-trained in advanced heart failure and critical care. So I would love to hear your thoughts on how do we kind of bring about a cohesive messaging and advocate for the group at large.
Well, I can't speak about the FTE part, and as I was listening to the last debate, I know that a lot of my former fellows who work in different areas, they all suffer from the insanity of basically having a 3 FTE job. And so my hats are off to those guys who are multi-trained, because it's not an easy pathway to hoe. Where I think one of the key, though, points of nascent societies and nascent fields like critical care cardiology is to have strong partnerships for advocacy whether that's advocacy for agreement across different specialties on what an FTE looks like in critical care, or advocacy on training paradigms, or advocacy on guidelines of how your CICU should be staffed. I think that when you partner with groups who have expertise or prior histories in advocacy in those areas, you become stronger together as a team. And I'll just, I'm here on behalf of the Association of Pulmonary and Critical Care Program Directors, and I think one place that we have been able to partner with the Society of Critical Care Cardiology has been advocacy with some of these boards that we have deep relationships with in advising, and have established their trust to some degree. There's people on the boards here, but they know us from the critical care side of things well, and we've established deep roots. From training you guys, as we get more critical care cardiologists, those people are going to be called on to start training the next generation. So where do they go to learn how to be better educators? And that's where these teams like the APCC MPD. Actually, I was thinking about this as I was sitting down. If we combine groups, we could be the APCC CCC MPD. It would be awesome. But through groups like ours, there are different niches which maybe the ACC can't provide, right? There's not an advocacy arm within critical care cardiology education for program directors that is probably worth the time of the ACC to bring up. So that's where an area of partnership can be actually really strong and robust.
I can add to that. When we started our critical care cardiology fellowship, we actually purposefully nested it within pulmonary. Why not leverage the 30 years of experience? Why not learn from them? And then, as you heard from Amanda earlier, why not work together and see how the combination of the fellows helps the education of both groups? And so with that, then I've gotten involved with the APCMPD as well. And again, there's a lot. It's been very helpful to me to work with them because there's a lot more overlap in what I do in helping to run our fellowship program with that group than with my CV leadership.
Before you go to Shashank, I think it's important when you're talking about education and programs, it's really important to have those competencies and to sort of understand what a critical care cardiologist needs to do, which is what the advanced training statement is working on. And because I think if you try to do education without understanding what those competencies are, then it creates just more confusion. And so I really await the completion of that particular work.
If I could just briefly offer a trainee perspective, because I'm accidentally sitting up here. That is my face, so I'm supposed to be here. But we actually, after NYU, I have the good fortune, in addition to being the world's worst scribe, I'm part of CCC Enthusiasts. And so after the NYU Symposium, we actually did a survey that we'll hopefully publish soon. We surveyed 40 trainees who attended the conference. 100% of them wanted to do training in critical care dedicated afterwards. But actually, so only 35% of them wanted to only do critical care. Significant, so it was a minority, but it was sizable, wanted to do advanced training in heart failure or interventional. And one of the biggest barriers is they didn't feel like they understood the competencies to do both. And also they didn't feel like they had the support to do both. And I think one of the sort of qualitative statements that somebody made is they wish that they had had guidance from multiple organizations to tell them how to do it. Also, someone was like, I don't know how to be an interventional intensivist. There's no guidance from anybody on how to do that. And I think that coming from Sky or people wanting through HFSA to have some of that information, I think even as an early trainee, because most of those respondents were either residents or first-year fellows, is actually at the grassroots level really important for us too.
That's a great point. Dr. Sinha?
First, thank you for the upgrade. It looks like I'm graduating to the level of Dr. Wiley, so that's a lifelong aspiration, dream come true today. Number two, building on this theme of advocacy, I really want to learn from the expert panelists how we can extrapolate from perhaps the trauma literature, which was very successful in uniting, and then getting to living across the Beltway is a whole different meaning these days, but trying to unite as a house of cardiology or critical care cardiology to then establish, what a level 1, level 2, level 3 center looks like. We're clearly not at a level where we can say, let's bypass, a shock patient to go to a level 1 center. But now is the time, I would argue, for us to start thinking in that capacity to get there within the next several years as we start building these regional networks of care. And so what are some of the lessons we can learn from our parallel specialties who obviously have decades of experience, particularly in the trauma realm?
I feel like as an emergency medicine physician, probably one of few in the room, I should probably comment on this. So yeah, I think that's actually a really good point, and it's actually something we've thought about a lot in cardiac arrest and resuscitation as well. So is there prioritization to bypass a smaller institution that might be proximal to get to the institution that has all the resources that you potentially need? The trauma literature is fairly legitimate and shows that you do much better if you arrive at a level 1 trauma center. But certainly there's regional conversations and there's things that need to be addressed to ensure that that's the right approach. The resuscitation literature is a little bit mixed, so it will be interesting to see how that bears out in comparison to some of the trauma literature. But I do think that when you do look at that, and it's some of that literature is a little bit old right now, so I think it would be interesting to revisit. But it definitely does show that regionalization and getting people to the right care quickly is optimal. I think as I hear the conversations going on, it would be very interesting to think about what that staffing would look like as well. From what I'm hearing about numbers of critical care cardiologists, so if you only have 200 people trained in that situation, you're going to be looking at very long transport times, which we know in the pre-hospital world is never optimal. So, but a great point, and something we're thinking about pretty aggressively in the resuscitation world too.
Another question I had for the panelists was kind of borrowing from this hub and spoke model when it comes to clinical medicine and clinical care, showing that if the hub is strong, the spokes can rely on it and get better. Could a parallel be drawn for societies at large as well, that if you have a hub society, then it kind of helps advance the footprint and the mission of all the parallel societies that may have sections within it, but not, classic example would be ASE, and Dr. Wali, I would love to hear your thoughts on this, where it's the premier organization when it comes to echocardiography. So when time came to build a curriculum for critical care echocardiography, it went through that system with, of course, input from colleagues within anesthesia critical care, pump critical care, and so forth. So in that sense, is it valuable to have a home base and then collaborate with all the other societies that have had a footprint for a long time, like Heart Failure Society of America may have done, or like SCI had done?
Yeah, this is coming to me. Well, I actually want to take a step back. I'm deeply involved in both the American Society of Echo and the Society of Critical Care Medicine. And Society of Critical Care Medicine was actually started by a cardiologist in the 1960s from my hospital, from Los Angeles General Medical Center. And so it's just sort of interesting to see how cardiology could start something that then becomes the model of multidisciplinary critical care society. And I really like for us to reflect on that a little bit. And even if you're thinking about this, how we look at trauma or how we look at other issues within what it is we do, I think the value of being involved in the other societies is because you look at how they approach their problems and solve them, and then bring that back to what it is we do. And then we look at everything from a slightly different light, from that light of being a cardiologist, at least for me being a cardiologist first, that then did training in critical care, was at the NIH with people that weren't cardiologists, and learned a lot of critical care from that. And then look at critical care very, very differently. Within echocardiography and bringing a lens of critical care to that. And I look at echo very differently than someone that doesn't do critical care. I'm more interested in how echo is performed at the bedside, how we make decisions, with patient management at the bedside. And a lot of that comes from my path and what I did. And that's what I try to bring to the committees that I'm on, whether it's at the SECM or at ASE. And I'm bringing that from a background of cardiac critical care. Again, looking at similar problems and then really looking for solutions from people that don't do what I do that can really help me sort of grow.
Yeah, I think that's a great comment. The hub and spoke that you referenced. So my kind of affiliation is through the American Heart Association, and I have to say, you know, as a big organization, there's a lot of opportunity, but there's also a lot of ways to get lost. And one of the things that I've been really interested in is trying to figure out where are these organizations that we can promote, we can optimize, and we can advance. And so, you know, working with SOC, working with leaders in critical care cardiology, and recognizing that kind of shared interest in promoting this group has been actually really helpful because, again, you know, within the American Heart Association, you can very much get lost. I'm an ER doctor. I can get completely lost at the HA. But I think having that opportunity to collaborate with organizations that are more specialty specific and bring them along so that they can experience all that you can get from these large organizations is, to me, an ideal model. And so I think, you know, through work with Dr. Katz and with Dr. Barnett and kind of thinking about how we can bring critical care cardiology to a prominent role in the AHA is, to me, that kind of hub and spoke model that we can really optimize that collaboration.
Makes sense. I think we will have time for both the audience questions. So Carlos first.
Thank you. It's been a great discussion. So kind of like, it seems that, again, going back to the concept of the Venn diagrams, SOC could be in the middle with all these nice interactions and getting nutrition from the bigger societies. But just flipping the coin and kind of thinking in a provocative way, we as, you know, trainees, faculty, we need to pay membership fees, you know, dues. How do we leverage that? But also when we look at the partners in industry, they might be asking, who are we going to fund this year? And it's a very provocative question that Dr. Dezfulian asked. If you're a trainee, can you go to the NYU Critical Care Cardiology Symposium, Houston Shock, Minneapolis, AHA, ACC, all these things happening? So could this also be like a mechanism where the societies help kind of like navigate and make those decisions for industry partners and us here having to dedicate our time and money and membership fees?
Dr. Roswell, Dr. Horwitz, I know we have talked about some of this within the ACC Critical Care Leadership Council, some of these challenges. So your thoughts?
I would say for the ACC Critical Care Cardiology section that we are creating sort of grant programs, fellowship programs, working with Abiomed, for example, and sort of sponsoring fellows to go to other level 1 CICUs for training. And so I think we're now bridging those gaps and making sure that our fellows can get around, and also that program also sponsors them to go to programs like Minnesota, NYU, and programs like this. And so I think we are now starting to do that. I think that was a great question, to make sure that the fellows are supported in the travel.
And again, to add to that, from the NYU perspective, I mean, we try to always function with the big umbrella picture in mind and invite everyone in from day one. The society, cardio nerds, everyone that we work with, to provide that space, because we do know that time is limited and finances are limited.
And I think we'll have time for one more question from the audience.
Oh, thank you. I'm Joe Palatinas from the University of Utah in Intermountain. I think I'm the only critical care cardiologist in Utah. But so my question is, I mean, we've heard a lot about kind of being collaborative and working in teams. And I'm concerned that the collaboration between societies is actually societies have different conflicting interests. And we mentioned we were to make an analogy to trauma, right? Heterogeneity in trauma care is bad, right? We can all agree about that. And I'm concerned that when we talk about our societies and the way we're staffing our CICUs, that we say right now we're saying, well, must have heard 6 or 7 times today that the way we're staffing CICUs, it's institution dependent. It works for this institution, it works for that institution, and what I'm reading into that is that there's heterogeneity in the way we staff our CICUs, and that's bad. And I think as a society, it's important that we recognize that the heterogeneity is not a benefit to us, that it is actually something that we need to address as a society. And I'm concerned that this term collaborating between societies, what we're essentially doing is we're being nice and not saying, no, actually what we need is 24/7 coverage in the CICU, or actually what we need is cardiac intensivists or pulmonary critical care intensivists, and we're trying to be careful not to step on toes from these other societies. And so anyway, I wanted to play devil's advocate here.
Thoughts from our panelists?
Well, I'm going to, in a friendly environment, I'm going to push back on that because I think since there's a little bit of a political flair here, we all could agree that democracies are heterogeneous and they're not very fast, they're very inefficient, but most people would agree that that works well for the good of everybody, even though it's messy and it's not that good. Just because you have homogeneity doesn't mean you're doing well for anybody. And I think I don't have to go any further than that.
Yeah, and I think, there are certain issues, I look at them clinical issues that are shared. Like shock is a shared clinical issue. And how we deal with it as cardiologists or cardiac intensivists, I think, or cardiac critical care physicians, and how medical critical care physicians deal with it. We all are dealing with like a very similar thing, or echo is the other one I think about a lot. And I find that within the collaboration within societies around those shared clinical problems are very interesting, right? That's where I really learn, and I think people really learn. And I had the opportunity to do medical ICU time. I don't know if they'll let me do it anymore, but I did do it. And it was really interesting to be back in the medical ICU in a large public hospital and sort of start to approach those problems from a critical care cardiologist point of view, and then to learn from my medical colleagues about like how they're caring for stuff and how we started to do stuff together. And I think the societies can kind of use that model a little bit to sort of advance what it is we want to do.
I just want to add, I think the societies really do have a role in, again, defining critical care cardiology, but also getting to the number. We keep on mentioning that they're not enough, and I'll just repeat this again. There's about 160 who are dual board certified in critical care medicine and cardiology. How many are critical care cardiologists who are working at a level 1 CICU all over this country who do not have that badge? And I think that's something the societies really need to come together to figure out who they are as well, bring them into the fold, because we talked about pulmonary critical care, we talked about others, but there might be a good maybe 700 or maybe 1,000 who are working in level 1 CICUs who are critical care cardiologists who are not involved in this conversation. So I think that is something that we can collaborate, SOC and ACC and AHA, to find those experts and make sure that we can standardize, which is, I think, to your question, and normalize the quality of care that's delivered in a level 1 CICU.
We're going to unfortunately have to conclude this discussion right now, but this conversation, as evident, must continue moving forward. With that, I want to thank my panelists and the audience for such an engaging session, and I want to invite back our president, Dr. Katz, for a few more remarks.